Hello, I'm Jared Weiss. I'm a thoracic and head and neck oncologist at UNC's Lineberger Comprehensive Cancer Center and a Grace board member, and it's my privilege to speak to you today on the topic of recurrent and metastatic HPV positive head and neck cancer. Now that's a bit of a mouthful, so let's unpack it and just make sure we're all talking about the same thing. In most cancers, when we talk about incurable disease, we say stage 4. Unfortunately, in head and neck cancer, things are more confusing than that because stage 4 cancer is sometimes curable, and there can be local only disease that is not curable. So what recurrent/metastatic here means is that we have cancer that unfortunately can no longer be cured, which we're trying to control, with the goals of extending duration of life and preserving quality of life. This kind of recurrence can happen in 3 forms: local only, that is not curable; distant only, which is never curable; and the combination, local and distant. And that presents in roughly thirds, with HPV-driven cancer maybe a little bit more to the metastatic side. Now, what's HPV? That's going to be the subject of other podcasts, but just briefly, we have 2 major biologic drivers of cancer. Classically, there was smoking-driven cancer, but now we have an epidemic of cancer driven by the human papillomavirus. Demographically, these cancers are easier to cure, but because they're becoming more common than smoking-driven cancers, there's plenty of recurrence, unfortunately, happening just because there are more of them. And that's our topic today, when we have an HPV-driven cancer that is no longer curable. Classically, these are detected by imaging and by physical examination. But I wanted to share with you a new technology that is sometimes useful in clinic. When cancer cells die, they shed their DNA into the blood, and it can sometimes be detected. There are certain mutations or changes in the DNA that are always present in HPV-driven cancers because it's the HPV DNA, the driver of the cancer. And I'm not going to walk you through this complicated figure, but I want to summarize its meaning for you, which is that if you can detect 2 positive circulating tumor DNAs in somebody who's had head and neck cancer, that's bad news. That predicts strongly in favor of recurrence and bad outcomes. In contrast, if you can't, meaning you either can only detect 1 and then it goes away, or if you never detect any, those patients do very, very well with almost no risk of recurrence at that point. This is a bit of a historic slide, but it shows us where the field has come. So this is the literature all the way up until immunotherapy, what we enter the immunotherapy world with. In the dark ages of old trials, the key endpoint was response rate, or the percentage of patients whose cancer shrunk at least 30% on a regimen. In the modern era, though, I think what we really care about are survival and quality of life. Survival, of course, very objective and easy to measure. Quality of life, extremely important. I would argue even more important than survival, but much harder to measure. So I show you the historic data, not through the historic lens of response rate, but through the modern lens of survival. These studies are too old to have quality of life measures for the most part. And what we see is that really we had no improvement for years until we finally got to the combination of 2 chemotherapy drugs, platinum and 5-FU, combined with cetuximab. So that's a gross oversimplification of where we start the immunotherapy era with. We have 3 drug therapy, 2 chemos, and a target agent with a survival expectation of about 10 months.